Welcome to Long Covid Doctor, an educational series for sufferers of long Covid. I'm Dr. Tim Robinson, formerly a family doctor, GP for 30 years, now GP lead for 3 NHS Long Covid clinics and a GP clinical lead in Long Covid across the southwest of England. This episode is on chest pain and Long Covid. In part 1, I'll talk about the symptoms, diagnoses and investigations. In part 2, I'll talk about the treatments, management and outcomes. Check out the references and resources and the links in social media in the show notes below. Just to say, any advice, diagnoses, treatments that I mention should only be considered after discussion with your own GP or doctor or medically qualified health professional. So here we go, chest pain and long Covid. So firstly, the context, the background. Chest pain and long Covid is quite common. It can occur in so many different forms and locations. And in my experience, in the 3 long Covid clinics I work in, it really is quite common and has a significant impact on our patients. This may be the worsening of a previous chest pain they have, or a completely new chest pain, never had it before, for no reason other than the fact that that patient has long Covid. And so, what are our patients actually experiencing? What are their symptoms and their associated symptoms with their chest pain? As I said, chest pain presents in so many shapes and sizes. The locations, the descriptions, exacerbating factors, the relieving factors. To simplify it, I've divided them into 5 groups, according to the types of symptoms the patients are experiencing. Firstly, there's central chest pain. Central sternal chest pain across the sternum, over the sternum, the chest bone, okay, as a dull pressure or a heavy weight, a band across, centering on the chest bone, that occurs with exertion. That it may radiate down the left arm or up into the neck. Then there's central or left-sided chest pain, which is positional, i.e. worse with changes of position, and that is worse when lying flat, but better when leaning forwards. Okay, so the central or left-sided chest pain that's worse with lying flat and better with leaning forwards. And then there's one-sided chest pain. I've done general front sternal discomfort. Now let's focus now on one-sided chest pain, i.e. chest pain that's occurring on one side only. Unilateral, sharp, focused chest pain, worse with inspiration. And then there's unilateral, one-sided, sharp focus, but it's worse when you press on a specific area, the focus, i.e. between the ribs, okay, or the base of the rib cage, along the costal chondral margin, or along the side of the sternum. If the patient says it hurts when I press on that patient's costochondral joint, the joint between the rib and the sternum, that is very specific. And finally, there's general across the whole rib cage chest pain, which is a general burning, lung burn, gripping COVID grip sensation. It's a general discomfort across the whole of the rib cage. And it is continuous. It's there at rest as well as on exertion and in any position. So that's different, obviously, to the other pains that I described earlier, the general chest pain, which is worse on exertion No, this type of chest pain, this general lung burn, gripping sensation, is there at rest. Patients even report that it's uncomfortable to lie in bed because of the whole of the chest feels uncomfortable, burning, and gripping. So lying flat in bed, there's no exertion whatsoever. So what is the next step? We need to make a thorough medical assessment to get a diagnosis. We need a standard history and examination to get the diagnosis. Specifically, we're looking for possible differential diagnoses, i.e. other diagnoses in which chest pain symptoms are present. The reason for this is that we don't want to be COVID blind. And what do I mean by this? Just because you've had COVID, it doesn't mean that a new problem, so in this case chest pain, can be put down to COVID. It might be due to one of other causes, one of many other causes, such as heart disease or cancer. And so COVID just happens to have occurred at the same time. So, as I said, we mustn't be COVID blind. We've got to get a diagnosis. Plus, we do a thorough history and examination to look out for any red flags, i.e. symptoms, signs that suggest something more sinister. What are the red flags in patients with chest pain? They'd be exertional chest pain, i.e. chest pain that occurs when you're exerting yourself, when you're walking upstairs, when you're walking up a hill. Then another red flag would be a fainting tendency for no obvious reason. Or another red flag would be rapid, excessive heart rate, tachycardia at rest. Other red flags would be, say, acute onset breathlessness or progressively worsening breathlessness, or oxygen saturation below 94% or desaturation more than 3%. If any of these are present, they're red flags. You need to act on those. You need hospital advice, certainly advice of a doctor, your GP. But if it's extreme, then obviously straight off to the ED in the hospital. Even if there aren't any obvious red flags, but your instinct tells you that something just isn't right, just ask. If in doubt, ask. Go to your GP. This is important. And so, it's back to the history. Firstly, the standard detailed history. We need to know everything about those symptoms, about the chest pain, the factors that make that chest pain worse, that bring it on, and the factors that relieve that chest pain. We want to know exactly what our patient is experiencing, how often they're occurring, and for how long. We need to know associated symptoms. Is there shortness of breath, for example? If it's chest pain, we need to know if there's breathlessness. We need to know whether there's a cough or faintness. We also need to know the impact of that symptom, that chest pain, on the activities of everyday living. It's handy to know the past medical history. Is there a past medical history of heart problems, lung problems? Is the patient on any medication for heart drugs, etc., inhalers, etc.? Or have they tried anything themselves? And if so, what and whether were those things they've tried helpful, yes or no? After the history, it's on to the examination. Thinking cardiovascular, we want to know the pulse rate. We also want to know the pulse rhythm. Is it regular? Is it irregular? More concerning, of course. We need to check the difference between the heart rate and the pulse rate, looking for example, new onset atrial fibrillation. We want to record the blood pressure, of course, thinking cardiovascular. We want to know the blood pressure sitting and standing, see whether there's a drop in blood pressure. We want to listen to the heart, of course. We want to listen for murmurs. We want to listen for a pericardial rub. We want to listen to the lungs, check for, crackles, crepitations. We want to listen for a pleural rub. We also want to listen for generalized air entry, make sure it's all symmetrical and the air entry is full in all of the areas. And saturations, we want to know oxygen saturations. That's history and examination done. Then it's on to investigations. Well, in primary care, your family doctor, general practice, the investigations will be full blood count, so blood tests first of all, the panel of blood tests we do. We want to know the full blood count, and we want to know kidney function, liver function. We want to know inflammation, whether the CRP or the ferritin is elevated. Part of the general long COVID blood panel is thyroid function test and HbA1c, looking for diabetes. Also included in that panel is the BNP, looking for heart strain. Maybe the patient has inflammation of the heart muscle, myocarditis. Other blood tests, D-dimer, looking for blood clots. Again, this is very much guided by the history. If you're pretty suspicious, you can probably diagnose it clinically, but a D-dimer blood test looking for elevated D-dimer levels in pulmonary embolism is obviously a blood test that we'll need to do if you have a high index of suspicion of a pulmonary embolism, as suggested by, say, one-sided chest pain, worse on deep exertion, and the chest pain is sudden. It has been of sudden onset with extreme shortness of breath. However, that having been said, we have to be a bit sort of circumspect about raised D-dimer, because it can be raised with if lung injury or after an infection, persisting inflammation. So got to take it in the whole context of the history examination. Also beware of false negatives. So again, like I said, you've got to take the whole story and examination into account. The only other blood test, just to mention in passing, is the troponin. You'd be wanting to send blood off to troponin if you have a serious suspicion that the patient has acute coronary syndrome or even a heart attack. But again, this is all based on clinical suspicion. Other investigations, chest x-ray obviously, chest pain, things to do with the chest. You'd want to be doing a chest x-ray, wouldn't you? Looking for heart failure or pneumonia or fluid on the lung or an enlarged heart even. Again, part of the whole cardiovascular investigations, you want to be doing a 12-lead ECG, looking for acute changes, ST elevation or ST uptick, saddle uptick for pericarditis. And then finally, thinking sort of things cardiovascular and irregularities to do with the heart, etc. Maybe a 24-hour or 3-day, 7-day Holter tape ECG, looking if there are associated palpitations. Then there are many other investigations that can be done that are done in the hospital. An angiogram, for example, or a cardiac MRI. These are all tests that really are the realm of the hospital. Just in passing, once we've been talking about angina and long COVID, whilst during our long COVID experience, 3 years basically, coming on to our fourth, has led to an increased identification of something called microvascular angina. So this is, for many of us, this is a newish condition, and it's to do with microvascular angina. So it's angina to do with the microvascular circulation, the mini blood vessels, but with normal coronary artery disease. Microvascular, mini blood vessels, macrovascular, if you like, is to do with the coronary arteries. So this is angina sounding chest pain with normal coronary arteries, but it's to do with the microvessel, the microvascular coronary tree dysfunction. These are the blood vessels that are less than sort of 0.5 of a millimeter in diameter that have been behaving abnormally. These are the blood vessels within the actual myocardial cardiac muscle itself that are, as I say, misbehaving, and it's thought to be due to a prothrombotic state and a pro-inflammatory state, which, of course, as we know about COVID in detail now, COVID, acute COVID, and in long COVID, it's a prothrombotic as well as pro-inflammatory state. Either way, microvascular, macrovascular is still angina. You want to be referring your patient to the rapid access chest pain clinic to have a CT angiogram to exclude coronary artery disease. If the coronaries are fine, then it's just a matter of the cardiologist then treating appropriately for this microvascular angina. Whilst we're on the hospital bit, yes, there are yet more blood investigations that can be done, thinking chest pain, chest things to do with the chest, the lungs, and there's the CTPA, there's the VQ scans, high-resolution CT scans, again, looking for other diagnoses for pulmonary embolism, for microthrombi, or lung fibrosis. Hospitals also do lung function tests, look at the oxygen transfer factor to measure how efficiently oxygen gets from the air sacs into the circulation. So, there we are. The whole list of investigations, both in general practice but also in hospital practice. So having done the full and thorough history and examination and investigated the patient, we're led to a diagnosis. And there are a number of possible diagnoses, which in turn govern the management and treatment of our patient with long COVID chest pain. And I've divided those chest pains into two groups. There are the 4 serious ones and there are 4 less serious ones. So first of all, the serious ones really are angina, which we've mentioned in passing. We've mentioned pericarditis. Number 3 is pulmonary embolism. Again, we've mentioned this. And number 4 is pneumonia. Those are the serious causes of chest pain in need of hospital advice and guidance. So angina I've covered, the macrovascular coronary artery angina, and I've covered the microvascular angina. Pericarditis, inflammation of the heart sac, that is this chest pain which is central or left side, worse when lying flat and better or relieved by sitting forward. A patient will tell you this. My chest pain, it gets better when I lean forward. They'll tell you that. That's pericarditis, really. Off to the hospital to be investigated and treated. And then there's chest pain that is one-sided, sharp focus, worse with deep inspiration. I'd be suspicious of a pulmonary embolism, blood clot on the lung. That, of course, needs to be investigated by the hospital, and the patient, if that's the diagnosis, the patient will be put on anticoagulant treatment, blood thinners. One-sided chest pain with inspiration, deep inspiration breathing, could be due to pneumonia. Again, it's off to the hospital to be treated with antibiotics, general resuscitation, and sort of you need that treatment. So those are the more serious presentations and diagnoses with chest pain. And then I've grouped the other for less serious, which are basically dealt with by your family doctor, your GP. So first of all, the one-sided, sharp-focused chest pains, worse with pressing on a particular part of the chest. So the patients will say they can identify where their chest pain is, and they usually put their finger very conveniently on that one area, i.e. along the side of the sternum or around the edge or down at the bottom. So the three common causes are, first of all, costochondritis, Tietze syndrome, and that is inflammation of the joint between the rib, where the rib joins the sternum. Okay, inflammation, simple inflammation of a joint, treated with anti-inflammatory drugs. And then there's intercostal, one-sided focal pain, and that is between two ribs. The intercostal muscles are the muscles between there are two layers, the internal, external intercostal muscles between the ribs. And again, they'll say, ouch, it hurts just there, or just there, or just there, wherever. That's intercostal muscle pain, and it's usually due to a strain of that intercostal muscle between the ribs. Again, it's a muscular thing, anti-inflammatory drug. And then there's costal margin inflammation. So cartilages at the base of the ribs, of the rib cage, can get inflamed. Okay, there are three. Ribs can be sort of grouped into three. There's the ribs that join the sternum bone. Then there are the ribs that are all stuck together along the base of the rib cage, the costal margin. There are three of those. And then there are two free ribs around the back, the 11th and 12th ribs around the back that are not stuck together. That is free ribs. So we're focusing really along the costal margin ribs, the ribs that are stuck together with cartilages, so that they can be disrupted, and that's uncomfortable. There is another, I'll just mention for completeness sake, inflammation of the one-sided inflammation of ribs and the tissues. Basically, it's something called Bornholm disease, which can occur as a consequence of a virus infection by the Coxsackie enterovirus. There's usually a fever, and it's an intercostal muscle pain. It's very rare. Just saying it for completeness sake, just so everyone knows, and so that people don't say to me, "Oh, what about Bornholm disease?" So Bornholm disease, very rare. I'm mentioning it just in passing. And so finally, that's the three of the common one-sided sharp chest pains. And then that leaves us to, which I've sort of put in the less serious category. And then that leads us to our final one, and that is the generalized, less serious category here. Chest pain that is generalized, not one-sided like the other three I've just said, the Tietzes, the intercostal, and the rib margin pain. This is generalized burning, lung burn, the so-called COVID grip, affecting the chest. And this is due to pleuritis. This is inflammation of the pleural lining, and that's what I'm calling long COVID chest pain. I'll explain a little bit more. Lungs are encapsulated in two layers, the visceral layer and the parietal layer of the pleura. So you've got the parietal pleura, visceral pleura, and there's a space between them that contains serous fluid. So they glide with normal breathing. So there's no rubbing. There's this serous fluid with breathing, inspiration and expiration. Then these two layers, these two pleura move and they glide together. So there's no rubbing, as I said. In long COVID pleuritis, there's inflammation of those lining of those two layers. They no longer glide freely, smoothly with breathing. And this makes the patient feel like this tightness. There's a burning sensation between these pleural layers, all over the chest, all over the rib cage. So there it is, pleuritis, the COVID grip. I'll explain this and the causes for it more fully in part 2. And then I'll explain the treatment for it. So there we are. I've covered if you like, this is my grouping of the different types of chest pain that our long COVID patients could be experiencing. And I've explained the red flags and the differential diagnoses, the other diagnoses. And sometimes annoyingly, unfortunately, the chest pain doesn't fit neatly into my five categories. This, of course, leads to a bit of uncertainty, unfortunately, and so referral to the hospital for further test investigations is wise and entirely reasonable. We don't want to miss something serious or life-threatening indeed. And so, in summary, there are 8 causes of chest pain, if you like, as I said, that I've grouped together. 4 serious, 4 less serious. The 4 serious diagnoses needing hospital secondary care are angina, pericarditis, pulmonary embolism and pneumonia. And then there are 4 less serious causes of chest pain that we may be experiencing in our long COVID patients, to be handled by your family doctor, your GP, primary care, namely costochondritis, intercostal pain, intercostal muscle pain, rib margin pain, and then finally long COVID chest pain, the COVID grip due to pleuritis, inflammation of the lung lining. Less serious, but certainly having an effect on quality of life, as well as all the other symptoms that our long COVID patients may well be experiencing. So that brings me to the end of the first part of my talk on chest pain in long COVID. In the second part, I'll focus on this COVID grip, the chest pain specific to long COVID, the explanation and its treatment. I hope you found that helpful and clear. Granted, it's complicated. As I said before, check out the references, resources and links to social media in the show notes below. As I mentioned at the start, any advice, diagnoses, treatments that I mention should only be considered after discussion with your own doctor or medically qualified health professional. So in the meantime, I wish you well for your long COVID recovery. Hopefully see you in the second part. Cheerio.